Welcome to the Deep Dive, your shortcut to essential knowledge. Today, we're tackling a really important area for your MSRA revision, osteoporosis. Think of this as your streamlined guide to understanding the condition inside and out, hitting all those key points you need for the exams.
Exactly. We've done the legwork, really diving into the details of osteoporosis for you.
So you don't have to wade through everything yourself.
Right. We're covering it all, from the basic definition right through to management and, the complications. And the focus is making sure this knowledge actually sticks, ready for recall when you need it.
Yeah, and to help with that recall, we'll be dropping in mnemonics, thinking about how this stuff might actually appear in exam questions, and sharing some, hopefully, handy memory tips.
Sounds good.
The goal is just to make osteoporosis clear and, well, manageable. Okay, let's jump straight in. How do we actually define osteoporosis?
Okay, so osteoporosis is fundamentally a systemic skeletal disorder. What that means is, essentially, your bones are losing mass, their internal structure is deteriorating, and this makes them weaker, fragile even, significantly upping the risk of fractures.
And it's often silent, right, until something breaks.
That's a really key point. It's often asymptomatic. You might have no idea you've got it until, unfortunately, a fracture occurs.
Okay, silent, but definitely impactful.
Yeah.
How can we remember that definition easily? Got a mnemonic.
We do. Try this one. Bones lose density, fragile. So BLDF.
BLDF.
It reminds you. Bone mass is low, density deteriorates, and fractures are the fragile outcome.
BLDF.
Yeah.
Nice and direct. I like it. Okay, so what actually causes this? What's the underlying reason, the etiology?
Well, it boils down to an imbalance in what we call bone remodeling. This is the body's natural, continuous process where old bone gets broken down and new bone is built
A
up.
constant maintenance cycle.
Exactly. But in osteoporosis, that cycle gets disrupted. Either the body isn't making enough new bone, or it's losing too much existing bone, or sometimes it's a bit of both. The whole turnover process is just out of sync.
Okay, so that natural renewal gets thrown off.
Yeah.
Are there different sort of categories of causes?
Yes. Broadly speaking, we split them into primary and secondary osteoporosis.
Okay.
Primary causes are often linked to things like natural aging, hormonal shifts, menopause is a big one, reduced physical activity, not getting enough calcium or vitamin D, certain medical conditions, some medications, and genetic factors can play a role too.
The secondary.
Secondary osteoporosis is when the bone loss is really a consequence of another underlying medical condition, or maybe due to specific medication someone is taking.
Right, so primary is more inherent changes, secondary is more triggered by something else. Got a mnemonic for those primary causes.
Yep. Try remembering AHDIM-MG.
AHDIM-MG.
Stands for age, hormones, decreased activity, inadequate nutrients, think calcium and vitamin D, medical conditions, medications, and genetics.
Great. AHDIM-MG. Okay, useful. So moving on from the root causes, what makes someone more likely to get it? What are the big risk factors?
Well, there are quite a few. The two biggest ones really are advancing age and being female. Women are significantly more affected.
Okay, beyond those.
Yeah, lots. Family history is important. Having a low body weight or a low BMI. Lifestyle things like smoking, drinking too much alcohol, being sedentary.
Right, the usual suspects there.
Pretty much. Also, long-term use of corticosteroids is a major one. And then certain medical conditions like rheumatoid arthritis or hyperthyroidism.
Anything else?
Yes. Things like premature menopause, being Caucasian or Asian seems to increase risk. Certain endocrine problems like hyperthyroidism, hypogonadism, growth hormone deficiency, even chronic kidney or GI diseases. And some specific meds too, SSRIs, antiepileptics, PPIs, glitazones. It's quite a list.
Wow, okay.
Yeah.
It really is multifaceted. Are there specific things that particularly ramp up the risk of actually getting a fracture? One of those fragility fractures you mentioned.
Yes, definitely. Some factors really increase the likelihood of those low-impact breaks. Obviously, having a lower bone mineral density, BMD itself, is key.
Makes sense.
Then increasing age, being female, low body mass, having a parent who had a hip fracture, having had a previous fragility fracture yourself, especially hip, wrist, or spine.
That previous fracture is a big warning sign then.
Huge. Also, current or long-term steroid use, conditions like Cushing's syndrome, high alcohol intake, we usually say 3 or more units a day smoking, factors that increase your risk of falling, and, of course, those secondary causes of osteoporosis we talked about. It's often a combination piling up.
So it's not just the weak bones, but also things that make you more likely to fall or put stress on them. Any way to remember a chunk of those general risk factors?
How about this one? Flags, crap meds.
Flags, crap meds.
Okay. It covers family history, low BMI, age, gender, smoking, corticosteroids, rheumatoid arthritis, alcohol excess, premature menopause, diet, thinking low calcium, sedentary lifestyle, and specific medications.
Flags, crap meds. That's memorable. All right. Covers a lot. Okay, let's drill down a bit. What's actually going wrong inside the bone itself? The pathophysiology.
So at the cellular level, it's all about that imbalance again between bone resorption, that's the breakdown of old bone by cells called osteoclasts, and bone formation, the building of new bone by osteoblasts.
Osteoclast breakdown, osteoblast buildup.
Got it.
Exactly.
Yeah.
Normally, these two processes are coupled. They work together in that remodeling cycle. But in osteoporosis, the osteoclasts become more active, or perhaps the osteoblasts become less active, or both. Essentially, resorption starts winning.
So more bone is being removed than replaced.
Precisely. And this isn't random. It's influenced by things like hormonal changes, estrogen dropping after menopause is a classic example, but also complex signaling pathways within the bone involving molecules like RANKL, which basically tells the osteoclast to get busy.
Okay.
The end result is less bone mass overall, and the bone that's left is structurally weaker. The internal architecture, like scaffolding, becomes thinner and less connected, making it much easier to break.
That paints a clear picture.
Mm-hmm.
So if we suspect osteoporosis, what else might be going on that looks similar? What are the main differential diagnoses we need to consider?
That's crucial, yeah. You need to rule out other things. Key differentials would include secondary osteoporosis. Is there an underlying cause we missed?
Then there's osteomalacia. That's different. It's more about soft bones due to problems with vitamin D or phosphate, not necessarily low mass in the same way.
How would you tell the difference?
Well, osteomalacia often presents with more diffuse bone pain and maybe muscle weakness. And crucially, blood tests would usually show low vitamin D, maybe abnormal calcium or phosphate, which you don't typically see in primary osteoporosis.
Okay. What else?
Hyperparathyroidism, overactive parathyroid glands, can cause bone loss. And importantly, you always have to consider bone metastases, cancer spreading to the bone, especially if someone has a known malignancy or unexplained bone pain.
So need to keep those possibilities in mind. Now, how common is this? What does the epidemiology look like, say, here in the UK?
It's a really significant public health issue in the UK. We think around 3.5 million people are affected.
3.5 million.
Wow. Yeah. And the prevalence shoots up with age. It's much more common in women than men. Looking at England and Wales, estimates suggest over 2 million women have it.
And that leads to fractures.
Absolutely. Around 180,000 fractures related to osteoporosis happen each year.
That's huge. What about the lifetime risk? If you're listening, what are the odds?
Pretty high. For women, it's estimated around 1 in 3 will have an osteoporotic fracture in their lifetime. For men, it's closer to 1 in 5.
1 in 3 women, 1 in 5 men?
And it gets really common in older age groups. Over a quarter, more than 25% of women aged 80 plus are thought to have osteoporosis. It really underscores how widespread it is.
It certainly does. Okay, given it's often silent, how does it typically present clinically? What signs or symptoms should make us think osteoporosis?
Well, like we keep saying, often there are no symptoms until that fracture happens. And they're usually fragility fractures, breaking a bone from a fall, from standing height or less, or even just minimal trauma.
And where do those fractures usually happen?
The most common sites are the vertebrae, the bones in your spine, the hip, and the wrist. Symptoms then depend on where the fracture is. If it's a vertebral compression fracture, someone might get sudden severe back pain, or maybe more gradual pain that gets worse when standing or walking. They might also notice they're losing height over time or developing that stooped posture kyphosis.
That height loss is a key sign then.
It really can be, yeah. Along with that new back pain, especially in older people, hip fractures usually cause obvious pain and inability to bear weight. Wrist fractures often happen when someone falls on an outstretched hand, but fractures can happen elsewhere too, arm, pelvis, ribs. So the presentation varies, but back pain and height loss are big clues for vertebral involvement.
Okay, so watch out for back pain and shrinking. If we do suspect it, how do we confirm it? What investigations are needed?
Right. The primary tool, the gold standard for diagnosis and measuring bone density, is the DXA scan, dual energy X-ray absorptiometry.
DXA scan.
Yeah, it's a low-dose X-ray, usually of the hip and spine. The results give us what's called a T-score. The T-score compares your bone density to that of a healthy young adult of the same sex. A score of Nagla 1.0 or higher is normal. Between a Meidigas 1.0 and a 2.5 suggests osteopenia that's lower than normal bone density, but not quite osteoporosis yet.
And osteoporosis is?
A T-score of 9 to 2.5 or lower confirms osteoporosis.
Okay, so DXA and T-scores are central. What about blood tests? Do they help?
They do, but mainly for ruling out those secondary causes we mentioned and checking things like calcium and vitamin D levels.
So what kind of tests?
Standard stuff often includes a full blood count, FBC, maybe inflammatory markers like ESR or CRP, kidney and liver function, UNEs, LFTs, thyroid tests, TFTs, definitely serum calcium and vitamin D. In men, we might check testosterone. Sometimes we need tests for myeloma, like serum immunoglobulins or paraproteins or urine Bence-Jones proteins if that's suspected.
So a fair bit to check for underlying issues.
Exactly. The NOG guidelines, National Osteoporosis Guidelines Group, give good advice on which tests when.
And then about those risk calculators, like FRAX.
Yes, FRAX, which NOG recommends, and also Q-fracture. These are really useful tools. They estimate your 10-year probability of having a major osteoporotic fracture.
How do they work?
They plug in various risk factors: age, sex, BMI, smoking, alcohol, previous fractures, family history, steroid use, other conditions. Sometimes they incorporate the BMD result from the DXA scan too if you have it. It gives a more rounded picture of risk.
And NICE recommends using these.
Yep. NICE guidance supports using either tool, often favoring FRX if you have the BMD data. They also clearly state who should be assessed, definitely all women 65 and over, men 75 and over, but also younger people with significant risk factors like long-term steroid use, history of falls, low BMI, smokers, heavy drinkers, those with known secondary causes, previous fragility fractures, or taking certain meds.
Okay. Any other scores we need to know?
We sometimes mention Z-scores. They compare your BMD to people of your own age, sex, and ethnicity. They're more often used in premenopausal women or younger men.
Right. And just to be clear, in straightforward primary osteoporosis, the bloods, like calcium, are usually normal.
That's right. The main value of the blood test is typically screening for those secondary causes or identifying things like vitamin D deficiency that need correcting. A bone biopsy is almost never needed for diagnosis.
Great. That makes the investigation pathway much clearer. So once you've got the diagnosis and assessed the risk, what's the plan? How do we manage osteoporosis?
It's really a two-pronged approach: lifestyle modifications plus medications.
Lifestyle first.
Absolutely fundamental. Things like regular weight-bearing exercise, walking, jogging, dancing, whatever's appropriate helps stimulate bone. A balanced diet with enough calcium and vitamin D is crucial. Supplements might be needed if diet isn't enough. Stopping smoking, cutting down excessive alcohol, and really importantly, taking steps to prevent falls, checking eyesight, home safety, medication review, maybe balance exercises.
Okay, makes sense. And the medications.
Yeah, so NICE guidelines are quite specific here, especially for postmenopausal women who've already had a fragility fracture and have confirmed osteoporosis on DXA. That T-score managed 2.5.
What's first line?
Typically, it's a bisphosphonate drug, usually alendronate taken weekly. Calcium and vitamin D supplements are almost always recommended alongside these drugs unless someone is definitely getting enough.
And if alendronate isn't suitable, side effects or something?
Then other bisphosphonates like risdronate or etidronate are alternatives. There are also other classes of drugs like roloxifene, which is a selective estrogen receptor modulator, or denosumab, which is a monoclonal antibody, often used if bisphosphonates aren't tolerated or contraindicated.
What about preventing that first fracture? Primary prevention.
For primary prevention in postmenopausal women without a previous fracture, the decision to treat is usually based on their FRAX score risk calculation. If treatment is indicated, again, a bisphosphonate like alendronate, risdronate, or sometimes ibandronate is usually the first choice. Roloxifene might be an option too.
And secondary prevention after a fracture.
Bisphosphonates are definitely first line there, along with calcium and vitamin D. If they're not tolerated or don't seem to be working, you might switch to another bisphosphonate or consider roloxifene or denosumab.
Are there any other drugs? I remember hearing about strontium.
Yeah. Strontium ranelate used to be an option, but it's generally not recommended anymore due to concerns about cardiovascular side effects. There are other treatments like teriparatide, a form of parathyroid hormone, romosozumab, an antibody targeting sclerostin, and hormone replacement therapy, HRT. But they tend to have more specific indications or are used in specialist settings.
And surgery. You mentioned vertebral fractures.
Yes, for some painful vertebral compression fractures that don't settle, procedures like vertebroplasty or kyphoplasty might be considered, where cement is injected into the fractured vertebra to stabilize it, but that's quite specialized.
Okay. And how long do people stay on these medications?
That's a really important point. Treatment isn't necessarily lifelong. The need for medication, especially bisphosphonates, should usually be reviewed after about 5 years. For some people, a break from treatment might be possible. It involves reassessing their fracture risk, using FRAX, maybe repeating a DXA scan, and weighing the benefits against potential long-term side effects. Ongoing monitoring is key.
And it's often a team effort, right?
Definitely. In the UK, managing osteoporosis often involves GPs, specialists like rheumatologists or endocrinologists, physiotherapists, occupational therapists, dietitians, a real multidisciplinary approach to give that holistic care.
Right, a comprehensive plan. What about the long-term outlook? What's the prognosis for someone with osteoporosis?
Well, it is a chronic condition, so it needs long-term management. The good news is that with early diagnosis, getting the right treatment, and sticking to the plan, both lifestyle and meds, you can significantly reduce the risk of future fractures.
So treatment works.
It does reduce risk, absolutely, and improves quality of life. But it's important to be realistic. Fractures can still happen even with treatment. The prognosis really depends on how severe the osteoporosis is, the person's overall health, and how well they manage the condition.
And the fractures themselves has consequences.
Oh, absolutely. Osteoporotic fractures, especially hip and vertebral ones, can be really serious. They often lead to significant pain, long-term disability, reduced quality of life.
And mortality risk.
Sadly, yes. Particularly with hip fractures in older adults, there's an increased risk of mortality in the year following the fracture. Hip fractures frequently need surgery and a long period of rehab, and unfortunately, many people don't get back to their previous level of independence.
And vertebral fractures.
They can cause chronic pain, that stooped posture, ongoing disability, and they significantly increase the risk of more spinal fractures down the line. And of course, all these fractures put a huge burden on healthcare resources. Hospital stays, rehab, long-term care.
So yeah, preventing those fractures is paramount for the prognosis, which leads us neatly into the complications.
Exactly. The main complication is the fractures. We've talked a lot about them, spine, hip, wrist being most common.
And the impact of those fractures.
It's profound. Chronic pain, physical disability, limiting what people can do, reduced mobility leading to loss of independence. It really affects daily life.
And the mortality risk again.
Yes, especially in the elderly, fractures significantly increase mortality risk. Plus, there's the psychological impact. Fear of falling, anxiety, depression are common after a fracture. And needing long-term treatment and rehab adds to the burden.
So it really is a condition where the fractures are the main event, with potentially devastating consequences. Okay, that brings us towards the end. And maybe a final thought for you listening. Just consider how a seemingly minor slip or fall, something that might barely faze a younger person, can have absolutely huge, life-changing consequences for someone who has undiagnosed or poorly managed osteoporosis. It really hammers home why being aware of the risks, assessing properly, and managing effectively is so incredibly important.
Absolutely. Nailing these key points is crucial for your MSRA revision.
And that wraps up our deep dive into osteoporosis. We genuinely hope this has been useful and high yield for your MSRA prep.
Yeah, hopefully those mnemonics stick.
Definitely use them. And remember, for loads more great revision resources, practice questions, and support for the MSRA exam, do check out pastthemsra.com.
And also freemsra.com for more resources.
That's pastthemsra.com and freemsra.com. Thanks so much for joining us on this deep dive.